So I'm very happy to welcome Dr. Julie Doughty, consultant, breast and endocrine surgeon at the Western Infirmary in Glasgow, Scotland.
Hello, nice
Hello.
to be here.
We're at the 32nd annual San Antonio Breast Cancer Symposium, and I bet you're tired.
Very tired, yes.
But you're making time to talk to us about actually a study that was presented here, a very important study that was presented a couple of days ago from the Breast International Group, the big 198 study. And what it reported on was a significant survival benefit for those patients who took Femara, also known as Letrozole, versus Tamoxifin after surgery. Those women were hormone receptor positive early breast cancer patients, and the results were very significant, and that's what we're going to talk about.
Yep. Well, the Big 198 study is a very large study of over 8,000 patients where women were randomly assigned to either Letrozole for 5 years or Tamoxifin. That's the main part of the study. Now that study, when it reported early on, there was a highly significant benefit in favour of patients who took Letrozole in terms of disease-free survival. And the Data and Safety Monitoring Committee felt it reached the boundary. So the patients in the trial who were on Tamoxifin, they were informed they were on Tamoxifin and given the option to take Letrozole. Now that's not the first time that that's happened in a study. It's happened in MA17 and it's happened in all the Herceptin studies. And when patients go into trials, you know, it's a big deal for a patient to accept to go into a trial. And if a trial is significant, then I think we have a duty to inform patients and give them the choice of taking the better drug. Now, because that's happened, that's complicated the final results of Big 198, and that's why at this meeting we've done this other analysis called that inverse probability of sensor weighting analysis, which is a complicated thing, but I'm happy to explain that to you.
And let me say it again, it's called inverse probability censoring weighting, not weighting, W-E-I-G-H-T-I-N-G.
Yeah.
What does that mean?
Well, that is a test which has been done before in clinical trials, and it's really when you stop a trial and give patients the option to take another drug, when you analyse that trial, so in Big 198, the 25% of patients who stopped Tamoxifin but took Letrozole are still included in the Tamoxifin arm for analysis. So what that means is you haven't got any more two pure patient populations of 5 years of Tamoxifin or 5 years Letrozole. So that analysis is the intention to treat, and in any clinical trial, the intention to treat is the robust scientific way to do an analysis. However, in this study, we know from every other study, so if you look at the IES study, ARNO, ABCSG, any study where patients start with Tamoxifin and then get an aromatase inhibitor, they will do better than 5 years of Tamoxifin. So because 25% of women actually got that approach, they will do better than if they had 5 years of Tamoxifin. So the intention to treat will underestimate the true benefit of Letrozole.
So the crossover happens for ethical reasons.
Well, I mean, if patients are in a trial and the early result shows it's highly significant, you know, we have to inform patients of the results, and patients and physicians can then discuss with the patients whether they want to take the newer drug. And this isn't, as I said, the first time this has happened. You know, in all the Herceptin trials, as soon as those first results came out, all the patients who got placebo got Herceptin. So
it's such an important message about the integrity and the importance of clinical trials. And so when someone who's viewing this may be on the fence, do I do a clinical trial? You don't get less than the standard of care, but your participation may result in the turning point.
Exactly, and if the result is highly significant early on, you know, now the monitoring committees will inform patients of those results, and then patients are then given the option to take that newer therapy, which I personally think is very important. It does make trial analysis more difficult, and that's why we've had to do this. But at the end of the day, you know, it's about patients and about what's right for a patient, what's the best we can give a patient.
And then just again to clarify for our viewers that Letrozole is the generic name, and patients commonly know the drug as Femara. So this has got to be very meaningful to clinicians, and now I'm wondering where you see this happening as far as adaptation in practice.
Well, I mean, I think just to go back to this analysis, when the big 198 was presented last year, we had the intention to treat analysis, and we also had a censored analysis. And the censored analysis is where you take out the patients who got letrozole. So all you've got left is the patients who are on tamoxifin. But if you had died, okay, so for the survival analysis, if you died in that tamoxifin group, clearly you can't then get letrozole. So the censored analysis, you've got more deaths, and that will overestimate the benefit of letrozole. So the true survival benefit is somewhere in between the intention to treat analysis and the censored, and that's what this IPCW analysis has looked at. It's weighted, it's given a weight to all the patients who said, right, I'm going to stop my tamoxifin and take letrozole. It's matched those with the other patients, and that's how it's been analysed to get a result. And the result is, as we thought, is in the middle, in between the intention to treat and the censored. And it is significant, but we don't give p-values for either censored or IPCW analysis. That's the correct thing to do, because the groups aren't perfectly matched, because the patients who said, right, I'm going to change to letrozole, weren't randomly allocated. They made that decision themselves with their physician. So you can only give a p-value if there's absolute no bias between the groups. But we know that IPC would be significant if you gave a p-value, because the confidence intervals don't cross 1. So, you know.
Emotionally, what the energy like for the women psychologically as they were able to make the switch from tamoxifin to letrozole?
Well, I think if you've been in a study, if you've participated in a study and you get a result and you're informed of that result and you're given an option, then, you know, psychologically that's a big plus thing for a patient, isn't it? To think, well, I've taken part in a study that's actually practice changing, and I'm now being given the choice to take that practice changing therapy. So, you know, I think women were very high, you know, very happy about it.
I would imagine.
Yeah.
So, having seen these results, do you feel that there are clinical differences between the available aromatase inhibitors, and that there's still a role for tamoxifin in the postmenopausal hormone responsive early?
Well, I think, I mean, tamoxifin is a fantastic drug. There's no doubt about it. You know, that drug has saved more lives in women with breast cancer than any other therapy we have to date. So I think there is still a role for it in certain groups of patients, because, you know, remember that tamoxifin and the aromatase inhibitors have different side effect profiles, and some patients may not be able to tolerate them. And also for patients with very low risk cancers, they may still have a role. But aromatase inhibitors clearly should be used in people, especially who are at high risk of early recurrence. Now, you know, are there differences between the aromatase inhibitors? Unfortunately, we have no direct head-to-head comparison trial. There is going to be a trial, or the trial's recruited, called FACE, which is a trial where node-positive women were randomly allocated to either Arimidex or Letrozole. Hopefully that will present in 2010, and that will give us the scientifically robust answer to, is there a difference between Arimidex and Letrozole? Until that time, though, you have to make a decision. And, you know, I think the big 198 results, even though the intention to treat, which is the robust scientific analysis, didn't show a significant survival benefit. It showed a meaningful benefit, and at 76 months there were 40 fewer deaths in the women who took letrozole compared to tamoxifen. And for me as a clinician, you know, significant or not, that's a huge benefit to patients.
Dr. Doughty, how long was the study happening before the realization hit that it was time to move women on placebo onto
Tamoxifen.
Yeah.
Yeah.
Yes.
The first analysis was 26 months. That was the first planned analysis. The primary endpoint was disease-free survival, and it was highly significant. And that's when that data went to the independent safety and monitoring committee. They looked at the data, so it was early on that the trial, that information was given to patients, and because of that, 25% of the women taking tamoxifen then opted to take letrozole.
Relatively short period of time.
Well, I mean, for breast cancer, the vast majority, there is a peak of early recurrence, so you know, potentially that's when you're going to see the most benefits in these drugs. So, and the number of events, it was highly significantly different in the two groups. So I think it was, you know, and then that was the planned time for reporting.
So what are your closing thoughts? You've been practicing oncology for a bit of time now. So as you look at where you were when everything started and where we are today, your own perspective, especially in the era now of personalized medicine.
I think we are moving forward. I think we now have, for things like endocrine therapy, you know, when I started off, there was tamoxifen and that was it. There was no other drug. So now we have, you know, a much bigger variety of drugs that we can give patients, patients who are post-menopause and ER positive, depending on, you know, if the patient has joint pains, if they've had DVTs, or if they're getting bad menopausal symptoms, you can kind of try and alter the treatment to what therapy best suits them. I still think, however, you know, Herceptin has been an unbelievably fabulous drug for HER2 positive breast cancer patients. But remember, you know, where I work, only 11% of breast cancer patients are HER2 positive. So that's a small number who can benefit. And I think we need to try and get more, like you said, tailored treatments for patients. And we're moving forward, but we've still got a long way to go on that.
Well, Dr. Doughty, thank you for making time and for representing Europe at the San Antonio Breast Cancer Symposium, and I hope you get some sleep.
Thank you very much.
Thank you.
Thank you.